Alex and I are so excited to be back for episode 3 of the Future Proof PT podcast. We're so happy to hear many of you reaching out to us and letting us know how and why what you're hearing about is resonating with you. And we're happy to be bringing a little bit different perspective than maybe a lot of what we're hearing. Lots of great content out there. We're nerding out on some things that we think are great to hear about in a dialogue fashion and really welcome the feedback. Please reach out anytime to us. Sign up for our newsletter. It has the email address. You can reach out to us. Any kind of feedback or recommendations, we'd love to have them. We're still obviously very new and building it in public, as you all know. Today, we're going to talk about examining the physical therapy supply chain, and we're going to look really deeply into the physical therapy referral continuum. And we're going to talk about a journal article that Alex flagged. He's excellent at flagging articles. I comment to him all the time. How do you find something so relevant every day? And post about it in such a smart way. So he flagged this article in PTJ from 2023 by Scott Peterson and John Hike called Optimizing Patient Outcomes While Maintaining Healthcare Efficiency. PT outcomes, not patient. And so we're going to look at that referral continuum. And I thought we'd start by just having a quick summary of why this resonated with you, what you think is great for physical therapists to take away from it, and what it's maybe sparked in you to think about in a different way.
Thanks, Dana. You're absolutely right. It is very exciting to speak to a brilliant mind, and it's really wonderful to have a bias-free, or hopefully minimal bias, minimal noise message, just speaking about the industry and sharing insight. And I think you are such a wealth of knowledge that
Ditto.
Anything that comes out of you, hopefully permeates. And I'm so happy that it's being discovered and it's being received well by our community. So signing up for the newsletter and following the podcast and ultimately reaching out to us, because I know you and I are both relatively accessible, and giving us ideas. I think the objective is for this to value to the end user and to the listener. And it provides some insights, regardless of even our conversation, that will spark an idea and that will be seeding these thoughts into people's minds that will get them to become more actionable and to start advocating for our industry. So yes, the supply chain methodology and economics of the supply chain in the PT world, right? The ever mentioned referral source and how dependent we are as at least outpatient PT community on referrals, especially in January, February, March, there's a shortage of referrals. And so there's that most PT clinics experience, and they panic. And then by the time it's June, July, August, there's an overflow of referrals and PT clinics that don't know where to find extra staff to supervise additional patients. And so this, I guess, imbalanced referral cycle. So going deeper into the mechanism of the referral cycle and actually understanding all of the steps of the processes into that patient being advised to seek physical therapy care, to patient actually being at the door, to patient actually going through the entire plan of care to maximize on the clinical efficacy of this clinical encounter. So I think, to me, this article by Saf Peterson and John Hike has been instrumental in explaining the two main paradigms in referral source, and the perspective of a physical therapist and then also a perspective of a payer, because both perspectives need to be appreciated to understand this path dependence of, again, that individual being told, this is the service, this is the industry that has the highest probability of helping your clinical problem. And then the payer finding the optimal way of both delivering care and providing access to care to physical therapy services and reducing barriers to that care being received. So yeah, let's talk about this.
So tell me a little bit about what they studied and what their findings were.
Yeah, so the main findings were that there was a vast challenge in inconsistency in referral pattern and referral continuity. And I'm just going to read just to be accurate, but the decision-making in referral process was flawed. Best practices in high-value referrals were not standardized. And so there's always an opportunity to enhance care delivery. There was a key finding of really have to ensure that referrals are based on clinical reasoning and urgency to avoid the necessary delays and overuse of specialty services. There was advocacy for clear guidelines and standardization of a referral framework, like the actual step-by-step process, right? And potentially, changing their paradigm and actually being the referral sources, starting to refer out, which we'll discuss a little bit later in this episode. And then addressing administrative challenges with a referral source. I think that like the boogeyman of prior authorization, right? We can spend probably a couple of hours just speaking about that and how that creates the real sludge in the referral network that deters people from pursuing further care because it creates a time constraint. And one of two things happen. People either become indifferent or people find care elsewhere that's not PT related. So there's a lot of opportunity, I think, to both improve the understanding of this referral cycle, but also improve the process. And then also looking into that payer insurance company, there is a payer-based need to understand what is an evidence-based referral pathway looks like. Like what, when, and how do you actually pay for the service being received, right? Like, and we've discussed this, promoting value-based reimbursement model and rewarding physical therapists for managing conditions conservatively before escalating care. In the first two episodes, we'll touch base on the fact that we are this unrefined gem that fails to recognize itself. And so the payers are perfectly fine with us not knowing our true value because it only adds to their value. And then the payers care about reducing administrative burdens and necessary referrals and ensuring oversight of high cost versus low value care pathways. Essentially, that very large range of care provision and how some referrals like essentially wind up in a setting where you just never leave versus others that have a very quick episode of care that is insufficient to actually receive anything of value. And then these are the fall-offs, right? But these are the people that will continue to pursue medical care through a more expensive, less advantageous clinical services and clinical modalities that are not us. So I think that this read itself sets a very good foundation with PT being in the middle of this referral cycle. And then looking into that top layer of referrals, which is the providers, the physicians and other providers, that states they have direct access to patients just pursue care based on availability of resources. And one of the resources that's starting to emerge is that physical therapists referring to other physical therapists, PTs recognizing that there's a niche service that they can't provide, but somebody else can. And so I think that's where we have probably an untapped opportunity to continue to specialize, continue to refine our niche care provision, so that we don't have to be jacks of all trades. We can have a primary care physical therapist. We can have a specialist physical therapist. We can have the unilateral niche provisions physical therapist and beyond, right? And then lastly, I think and this is more of my insight, I think in the States, in 26 full direct access and 40 some form of direct access states, physical therapists that receives patients from the street, from direct access, like there's an incredibly low rate of cross referrals or PTs referring out to other professionals. And how much of that is an untapped potential of building your clinical network with physical therapists being in the middle, your primary care provider of musculoskeletal services. And then you are the one that's triaging services to the specialists that are needed. So we have both lack of a utilization of such services, and we also have lack of understanding of what are the triggers for somebody being referred out, right? Is it a time-based trigger? Is it a complexity-based trigger? Is it an individual-based trigger that, like, I don't think this is working for me, so who should I go next? And so PTs, I don't think, are both well-versed and also recognize these triggers as existing, and there is guidance towards us being this value-based factor. So that's my spiel.
I've jotted down 5 different directions to take the conversations. I may work my way up backwards in my notes here, because that's fabulous. I can picture the therapist in the middle of the referral cycle, so that was really helpful. Thank you. We can be primary care and specialty care, just like physicians can be primary care and specialty care. And just like behavioral health providers, which I always see these as the triad of primary care, they can be generalists and they can be specialists. You know, your specialist who focuses on ADHD in children, behavioral health, where they focus on substance abuse, right? You need generalists and specialists. But I worry we don't need, and we talk a lot about, I see a lot of this online, is you can just come to me for your primary care. And I'm an independent primary care provider. And that language gets dicey. I worry about us leaning too far into that and embracing the nuance, meaning we don't like when physicians, primary care docs, think that they can manage someone's low back pain alone, or when they don't refer out for falls, someone with balance who needs to work on gait training or whatever it may be, because we're the right primary care provider to be providing those services, the range of services that fit into where we're the highest value provider. So why do we then, for those who are, kind of starting to think this way, I'm hoping to question that thinking. Don't mimic what we already don't like. We can be the primary care generalist physical therapist as part of a primary care team, but we cannot, under our licenses, give vaccines and give the flu shot and perform an annual wellness visit and bill for it. We're all part of a healthcare team. Awareness is the problem. We don't have enough physician awareness that we can help them. And then I go right into my value-based spiel where as soon as, you're paid on the outcomes, you care about bringing the PT into your team to manage those conditions because you're not transacting dollars. You're being paid for how well you do your job. So there's those. And then let you comment on or any thoughts on that before the couple other things I know.
I think that's very well articulated and spot on with all of your points. I think there's an interesting thought experiment that we can play, and hopefully the audience can play along with us. And that is, when was the last time when you received a referral for physical therapy, that you denied care and actually sent the patient elsewhere? When you thought this is not the right discipline for you, right? And I'm not talking about the extreme, like red flag of medical crisis needs to be in an emergency room, or someone who has like those blue flags that there's a potential abuse of industrial injury or work-related injury. I'm talking about people with yellow flags that have a much larger psychosocial involvement. But we all know that pain tends to be this blanket term. Like, you have pain, well, go see a physical therapist. So you do receive a referral. These are the patients that are much more appropriate to receive behavioral health services for their quote unquote persistent pain or pain. And there are other disciplines that do really much better job than we do managing some of these cases. And yet, historically, we as PTs take everyone on. We provide care. We focus on things that may be classified as not the highest value care, because we can always find something, right? And having been, I guess, having a privilege of being a dinosaur physical therapist,
Two of them.
right, having been doing this for a couple of decades now, you realize that there's companies that are actually indoctrinating these young clinicians, myself was included, to look for these problems where the problems may not exist, where like they coach you, well, look for postural discrepancy, ask what else should we be managing. And to me, I think that's actually low value care, because you are creating a nocerbic engagement. You are helping someone catastrophize about their state, and that does not create need. That actually creates catastrophization. Again, I'm not talking about someone who potentially has 3 or 4 or 5 comorbidities, each one needing to be managed through physical therapy services. I'm talking about someone who has this sub-threshold issue that they're managing and coping well with, and yet we're still trying to pile on and keep them in our clinic, in our industry indefinitely, instead of sending them out or giving them the liberty to leave, to complete the opposite of care, ensuring them that we are your physical therapy resource. When you need a physical therapist for your physical therapy need, please come back to us, because we are trying to generate revenue. We are trying to provide service for fee or for reimbursement, right? It's a blue term. So that's a very interesting thought experiment. Hopefully that resonates, is that since we're talking about referrals, how many times do you actually receive a referral that you know will be better served receiving social behavioral health services or something else that you still retain in your clinic because, it's February, that your patient roster is low, you have all these openings in your schedule. So why don't we just keep you in for 6 weeks and we'll just work on whatever? And that's I think how we build self-efficacy. That's how we build self-reliance as an industry, by actually acknowledging that this is not the right candidate for my care, my service, or this patient will do much better with someone who has better training, who's also a physical therapist, but who understands this diagnosis, this treatment better than I do. But they're across the street and they work for a competitor. Should I really refer them to a competitor? Absolutely not, right? These walls, like that's a steel wall. There's a moat and there's alligators swimming in it because that patient stays in. So that's, to me, that has always been a disappointment. But what do you think of that?
I couldn't agree more. I have a really good patient example. If you can imagine, I haven't treated full-time or more than 1% in the last 5 years, but I have a patient example from, this really dates me. This is from the year 1999. And I was treating, I was just a couple years out of school. I was treating a I had left Kessler Institute for Rehabilitation's inpatient site, and I went to open one of their outpatient sports medicine clinics I was the staff therapist, and there was a manager, and it was really an awesome experience. I had a wonderful experience at Kessler altogether. And this particular therapist that I went with to the satellite was the favorite physical therapist of a prominent orthopedic surgeon who specialized in shoulders, did a ton of rotator cuff repairs. So I had one of his rotator cuff repair patients came in. It was first day. And I went to greet them, and he had classic shuffling gait, flat affect. My license does not allow me to diagnose Parkinson's disease, but I would have bet my new home that I just bought that this patient had Parkinson's disease. So as I was doing the history and asking them about the medications they were on, and we were kind of going and having this conversation before we began the examination, it was clear to me that there was no awareness that there was some kind of a neurological disorder going on. Remember, this person just had a rotator cuff repair. And that orthopedic surgeon, as I got to know them a little bit, a couple weeks, and spoke to the wife, and I flagged that I was concerned of some of the presentation, that they should see a neurologist. And then when I was, they had never heard this before, the orthopedic surgeon, who was a physician, had to have watched his affect and watched him ambulating. And no one had said a word to them. Living in these silos, right, where you're a physician and this person clearly has some neurological condition pointing towards potentially Parkinson's disease, and no one is going to pick up the phone and call their primary care or refer them to a neurologist. So remember, I'm just doing things based on logic. I asked if I could reach out to their primary care doc. Of course, they hadn't seen them in a long time, and mentioned what I was seeing. And of course, extremely grateful. They went to see their primary care doc and were very quickly put on treatment for Parkinson's. Again, clear, I'm not a diagnostician of Parkinson's, but when there's signs and symptoms that you should be making a referral, putting that person within the reach of the right provider and working to help coordinate that care, because it was the right thing to do. And that right thing to do should sound so obvious, but we watch it not happen in physician specialties all the time. That was one stark example, but we all know this happens regularly. It's our job, I think. I wholeheartedly agree. Whether it's to another therapist, it could be to another physician, it could be to behavioral health, but where it's appropriate, because a different provider needs to be the one to provide a service, how could we not be doing it? And I will add here, as I've brought up a little bit in our first 2 episodes about trying to connect with primary care docs, use as a way to build strength in your referrals, but also to demonstrate that you can be a value-based partner. Things like, not having had an annual wellness visit and not having your flu shot. Have you had a colonoscopy in the last 5 years, knowing their age range, just knowing the guidelines? And then suggesting that there are some good practices in the area. Would you like me to connect you with them? That builds a natural camaraderie between you and this high-performing, value-based primary care practice, where it just becomes a natural partner together and get into these alternative agreements. So let me stop there.
I think so. Good job on flagging that, right? And how wonderful it was for you to actually learn it early in your career. I think there's a clear dichotomy of physical therapists that have a job and physical therapists that have a career. And someone who has a job just shows up, takes care of their patients, and goes home. Someone who has a career is going to be invested enough to understand that there are limitations to your practice, and there are limitations to your capacity. And so that one size fits all just simply doesn't work. And I think we also are looking at things from a slightly siloed perspective, because I'm in Chicago. So I have this vast luxury of having 300 professionals within a 2-mile radius from me. But think about the PT clinics in more rural areas where potentially you are the only healthcare provider in a 50, 100-mile radius. So you are going to see that overcast of patients with questionable diagnoses, with questionable clinical presentations. I think that's where it becomes ever so important for you to build a clinical community where you become a resource, right? You are a physical therapist, but you are a professional that has a healthcare community that surrounds you, that that you can use. And if something is questionable, you are advocating for the patient. You are the resource for the patient and for the community. because you know when things just don't feel right or the things need to be looked at by someone else. In turn, being in Chicago with 2 PT clinics in every corner, pretty much, every clinician has their strengths. And certainly there's enough of the patients that fit the general model, but there's enough brilliant physical therapists in Chicago that really practice on top of their license and are subspecialized. And I know that they do a wonderful job taking care of these very difficult cases that would be much better than I ever could. But there's always a barrier. There's always a constraint that if I refer out of sight of my brand towards another brand, right, that becomes a major constraint and a cause for almost a disciplinary action, because how dare you chase away our revenue source? Which I think when that becomes the case, then you have to question whether that is the discipline or that is that employer you want to work for. But that's a different that's a different conversation altogether. But it is, again, like your job as a professional to understand your limitations and to understand how to use your community around you to be the resource to your patient and to that community.
That's being a great physical therapist. And that's what the DPT, that elevated degree was supposed to, in my mind, put the profession in a different place. And we have to amplify that message, because a lot of the assumptions that we make are not necessarily right for the reasons that we think they are. It's more of a lack of awareness. Generous assumptions about why things are or aren't happening can be tremendously helpful, right? And love your point about, we shouldn't refer out to anyone else, even another therapy clinic. But the way human behavior works, and I'm no psychologist, but when you give value, you see it in social media all the time. When you give value to people, there is a sense of they want to be able to give back because you didn't ask for something. We're just doing the right thing. That goes a long way. Therapists who've worked outside of traditional clinical care, maybe you recognize that once you get into the business world, you'll be really open to thinking about what's best for the patient. And a lot of times it's as simple as they don't have a primary care doc and they're not getting their mammogram along the correct schedule. We should be identifying those things and helping those patients. I'm going to tell you one more. I was at a conference, a very, very tiny conference, and someone from Kaiser Permanente was speaking, and he said something that blew so many folks' minds, but it makes complete sense, right? In a value-based system. He said, he's an orthopedic surgeon, and he said, what we're required to do by Kaiser doesn't matter who you are. If you are a provider and you are seeing a patient in Kaiser's system, and you pull up their chart, the first thing you do is look at all of their quality measures and see if they've had all of their tests done, what gaps they have for the year, and it's your job to schedule them. It doesn't, I'm an orthopedic surgeon who specializes in, let's say it was shoulders. My first job is to schedule their mammogram in the room, face-to-face with the patient. You know the likelihood of that patient actually going for that mammogram, how high it is when the doctor told them to do it right in there, right? What they studied was when they changed the system and required this, the time to get diagnosed with breast cancer dropped, of course, precipitously. But then it dropped even the time frame between when they had the mammogram and when they found out the results and when they had the next biopsy, and it actually saved lives. And of course, it saves costs because you're catching things earlier when they're more treatable, and it reduces suffering and it reduces the spend that's incurred when you try to manage end-stage cancers, right? So again, all aligned. But I can't imagine in the fee-for-service world where any orthopedic surgeon's manager would say, first thing you're going to do is look at their quality gaps and make sure they've had their preventative tests. That should be the norm.
No, I mean, absolutely, right? I think that's where we start just fitting that the label that the world assigns to us. That's like the Carl Jung's quote, right? If you don't know who you are, the world will tell you. It's like what the world is telling us, that we have to overprovide care, or we have to be this one size tool for everyone. And ultimately we just morph into that without being a resource, where I think like a physician has a Hippocratic oath and has a responsibility. A therapist has their responsibility, and each one of us can really act more on patient advocacy care. provider. And that does mean taking care of the entire individual, not a body part, not a diagnosis, not a CD10 code, but taking care of an individual. And that means asking them questions that are pertinent to their well-being and sending them where they need to go. I guess another good experiment, right, would be if an ACO, if they're trying to provide a value-based contract with a therapist, they can ask them, how many patients have you cross-referred? And if they say 0, then I wouldn't give them a value-based contract, because that shows that they're less likely to understand constraints of providing just high-value musculoskeletal care and the constraints of your own profession. So, yeah.
What came up for me there, I love that, Alex. What PCPs really hate, especially when they enter into value-based contracts where they're responsible for total cost of care, and even your, old school doc, what they hate is when they feel that they're the quarterback, they're truly the center of that person's healthcare experience and help to guide them. They hate when they don't know what happened to their patient. There are ways, the more advanced accountable care organizations, some of them will opt into or connect into their health information exchange, or they will adopt an admission discharge transfer feed. So they find out some of these things by connecting electronically. But a common thing that happens is like patients being admitted to skilled nursing. The skilled nursing facility never lets them know they were there, never lets them know they were discharged. It's in a complete vacuum and no one cares, because what's the incentive? The primary care docs don't send us patients. The hospital does. Why should I connect them? Crazy, right? Like the highest risk of readmission on discharge is going to be in the first 10 days. They're not going to think to just get in with their doc. You should be scheduling it. But what's the incentive to do that? Right? It doesn't exist. But how about practically speaking? You're a PT. Orthopedic sends you, patient went around their PCP, went directly to an orthopedist. The orthopedist sent them for therapy. Shoulder, let's stick with the shoulder today. You know what builds amazing trust between you and the primary care doc that you want to work with more, you're hoping to get more referrals from, with consent from the patient, letting that physician know you will have a referral, you're managing this patient for rotator cuff tendonitis, Dr. So-and-so sent the patient, you want to let them know how they're doing. And by the way, they mentioned they haven't been there this year, you're happy to help them book for their annual wellness visit. You'll become the MVP of a primary care doc's office in no time, because you are helping connect the dots. And connecting the dots is what accountable care, a lot of it is about. Be a coordinator of care. I know we're not loaded with time, but we're moving in a different direction. Yes, it costs time, but a well-enabled front desk can help with that scheduling, right? A well-enabled technology solution can help you dictate that note quickly and get it off. We have to be doing these things, even if we're not paid yet, even if not in a value-based contract. Spend the next year doing some of this prep work. Maybe we can put together like a one-pager for our listeners where we share just some actionable tips for what you can do to build trust and strengthen your referral relationship with providers in your area, behavioral health providers, primary care docs, right? Does that resonate with you?
I think that's actually spot on. There's a lot to unpack there, right? Like building trust and becoming a resource, becoming a solution instead of just a care provider. That's one. The other really important factor is probably a slightly different chain of thought. A patient that does not complete their course of care. So all of the drop-offs, right? The attrition in some of the practices is like 50% of patients that slowly fade away don't complete their assigned course of care. And how many therapists take an initiative of actually informing a referral source that this individual failed to complete the course of care? Usually these patients just drop away. And then in 3 months, in order to complete the course, you just dictate a very shallow note that closes this specific episode of care. But that, I think you can create specific triggers that if an individual has not been seen in more than a week, that you really need to contact the individual, and you need to contact the primary care provider, whoever the referral source is, because that referral source is under the assumption that this individual is still continuing to receive care. And I think that's just good communication, right? That is a good customer service.
That's right.
Outside of care provision, that like this individual failed to complete the assigned course of care. I just need you to know this. And we've made these efforts to count the patient, and whatever the reason is, it's just good communication. That is you being part of the entire ecosystem instead of you just seeing yourself from that silo that I'm just going to give my course of care, right?
I might even go a step further than that, than saying that they didn't complete their course of care, which I think is brilliant and it should be done in all cases. If someone sent you a referral because they believe you're the right person to treat their patient, and could be if it's the PCP, it's their medical home, I would maybe phrase it just a little bit differently and say that they have achievable goals that we've worked carefully on that are individualized, and they haven't continued to show up to achieve those goals. Here's what I see might be the barriers. Can we partner in trying to help them get to that stage? And here's what I think will happen or could happen if they don't achieve those goals. And maybe it's, that primary care doc has community health workers. This is much more commonplace now than we imagine. We know they have some concerns about their safety at home. If they have a community health worker, or they have a medical social worker that makes home visits as part of the practice, they want to know that this is your concern and are grateful because they're responsible for these patients if they're in a value-based arrangement. And assume that primary care was going to all move to advanced primary care. I can't predict the future, but if I was forced to say, I would say 75% in the next 5 years, primary care will be in advanced primary care. It's the way they make more revenue, and that is driving the adoption. And then they love it and they stay in it rather than leave the medical profession. I'm got a little tangent here, but I think therapists can take a little lesson sounds patronizing. I don't mean it that way. But when I've spoken to physicians working in advanced primary care practices, when they get into that new team-based approach and patients feel that their services are being wrapped around them and they are their go-to source, physicians who are on the brink of leaving the profession are now committed for lifetime to staying in the profession because they have such satisfaction every day. I have heard this story from physicians saying, I was ready to leave. I mean, this was my dream to be an internist. I had no idea that primary care could be practiced like this, right? Where there's behavioral health and social work and physicians and NPs and nurses, and they're all working together. And they all know each other and they're all coordinating care. This is beautiful. This is what we should want. And if we can get PTs as part of this, and I would say OTs too, we will have such higher patient satisfaction rates and retention of therapists, right? It's totally great and fine for any clinician who wants to leave clinical care. No shackles on us. But I suspect that there would be many more happy PTs and OTs if you were functioning in this team-based approach to care when you're a primary care therapist, providing more generalized services, which can be pretty broad. There's a whole lot more reason to be committed and attached to that work.
Well, I think that there are definitely some therapists that are already practicing this model that you were describing, where like if you have a specialty or a niche practice and you have your own specialty community, you become that go-to resource. There was a brilliant clinic in Chicago called Entropy Physical Therapy. So Sarah Haig and Sandy Hilton were two therapists that were there. And I think to give them the shout out that they provided the exemplary service to their community, and that it was their community. They were the resources. They had specialties and they did a great job expanding knowledge. So they welcomed these scholars from all over the world to come and speak in Chicago. So I had a privilege of listening to Lorimer Mosley and other brilliant clinicians from all over the world, but they also were a resource to their community. So I think that there was a significant amount of patient cross-referral because that was like, they weren't in an effort to keep the patient indefinitely. They were trying to advocate for the patient's needs. And so essentially they were outliers because 10 years ago, 15 years ago, they were already primary care providers in their own right. And there's a lot we can borrow from that specific model. One clinic being a resource in the middle of Chicago, downtown Chicago, giving this exemplary service. Yeah, there's a lot we can do. And going back to that article, I think that the article is physical therapists can become a resource to the community because we have a common goal with the community, with the providers, with the referrals. We want to optimize patient outcomes and maintain healthcare efficiency like that. So we're all kind of working on the same problem, but from different angle. And we can only do better when we act like a resource, when we act like a provider that actually takes the patient's interest as a primary source of attention. So yeah, like that would be really good to see if more therapists, if more listeners take this model and then go to the clinic tomorrow or whenever, and start to reconsider what I'm doing. Maybe I can be that resource. Maybe I can start establishing this PCP community around me where I become their MSK resource. And in return, once I have their MSK resource, I get the PCPs that I can cross-reference with, right? So then I think you are then becoming a physical therapist with a capital P and a capital T, right? You're not just a physical therapist, but you are a physical therapist who is doing what they can to provide exemplary care.
We're talking about actionable insights and how to be a resource to primary care. And I'll bring up the Medicare Shared Savings Program because it's such a large program that encompasses now almost half of Medicare beneficiaries that are in fee-for-service. When a practice enters for the first time and they're a new participant, so this is an accountable care organization. So it's a group of providers that come together, sign a contract with the Center for Medicare, and agree to certain measures that they're going to follow and agree to a benchmarking of spending. So looking at what expected spend should be for their population, and data helps to inform that. And in the beginning, when you participate in the MSSP, the Medicare Shared Savings Program, the first track A, B, is upside only. So what that means is if you save money from prior years, again, because you're providing the right care at the right time with the right provider, and you save money, you earn back a percentage of the dollar saved. But I bring up the beginning part where you're for having a first signing of a Medicare Shared Savings Program contract, and therapists who just learn the basics of the shared savings program and the levers can come in to these new practices as a resource to share how we can provide early access to high quality musculoskeletal care to help address some of the high variability, unpredictable downstream spend, show you how we can help you be successful in this program. And when there's no downside risk, and you have someone coming to you with a solution and you're in something brand new, it's really appealing to a brand new group that just is trying to figure everything out to say, oh, someone knows about this program and can share how early physical therapy, how they're going to give us early access to their care, how early physical therapy is going to help us address our low back pain patients. And now we have a partner, and it gives that sense of stability. I would even be going to practices that are not in an agreement yet. You know, you can look up who's in the shared savings program now. I would be looking to see if all the, primary care docs in your area, are any of them not in it. You can join with them. You can help them get into that contract. They'll be the participating provider physicians, and you can actually sign a specific agreement with them. You can get into an agreement with them from the beginning. Here's what we're going to commit to. And this is done commonly with home health agencies, skilled nursing facilities. PTs are way more efficient than all of those other sources. So go in and offer to be a partner. Offer to help them with the application to CMS. There's lots of ways that you can become the foundation for practices or a community's entrance into these programs and learn with them, build together from the ground up, and you become part of the program as it's being constructed.
I think, Dana, what's missing here in the words of Fiddler on the Roof and the words of Xavier, we need a Yentl, right? We need a matchmaker to make me a match, find me a find and catch me a catch. That is, I think that there is that middle connector that is missing, that it can potentially do exponentially positive impact on both communities, because you can provide this fine middle ground for the therapist to help them understand and to help them gain access, and then in return you get access to these skilled individuals that have been prepped to be able to provide care on this level, which is I think that is the perfect be shared moment. That's the matchmaking moment.
I love that.
Yeah, but there's until the matchmaker does the magic, right? I think the therapist may, even if they listen to this, they may take this, and then they will be on that eternal search for that connection, right? So I think that's the opportunity where, like, someone with your level of knowledge, I think it's so good for them to understand and hear that there are opportunities outside of this fee-for-service model that is just grinding everyone down. There's opportunity to expand yourself to other avenues where you can actually enjoy what you do and not feel like you just are on the assembly line. trying to get through as many people as you can in a day. So yeah, it's really great. I've just learned that too. So it's really wonderful to hear that there's this opportunity for a therapist to go in and actually offer services.
Help them apply. I applied for models that I had to teach myself. I attended webinars and I figured out how working in a health system and then working at a startup, how to do these complex applications. We all have the ability to do this. It's just a matter of doing a little research and learning. And there's resources at Center for Medicare to help you be successful in it. The hard part is this administrative work. So if you develop what we talked about earlier, right? You start connecting more with the providers in your community because there's still like plenty of opportunity for lots of participation growth in these models. You become part of the structure from the beginning and really think broadly about what our role can be. We all know as therapists that we have this expanded knowledge and the generous assumption we can have here is because everyone's worried about their own cheese. What was that book? Don't Steal My Cheese or Don't Move My Cheese
Move
or
my
something.
cheese, right?
Yeah. That goes back a long time too. But assume that there's just not a good awareness of how you connect with them and how you can support them and build something together. You can build a community of accountable care. Think how beautiful that word is. I am accountable for the patients I care for. It changes the whole paradigm and allows us to have the impact that I feel. When I graduated with my MPT in 1998, I felt that this was the mission of this profession, and it can be realized if we're aware of what the possibilities are and the fact that there's very good reasons why many are not aware of what we can do to help and be a part of the day-to-day care of their patients.
Yeah, I think again to bring the full cycle in the same journal article, there's an extensive talk about a care continuum. So care continuum is about creating these feedback loops with patients, with community, with referrals, providing a data-oriented approach to this clinical care provision through these feedback loops. So once you establish a community, that it becomes a self-perpetuating cycle. So once you establish these feedback loops, they start to feed on itself, and you're building already from an organizational structure that you didn't have before. So there's essentially an unrefined asset that is just waiting to be utilized.
That's right.
But I guess now it's the time. So like, are we going to start a movement, or is this episode going to go into that eternal Siberia of all episodes and never be discovered? It would be wonderful for us to receive feedback and to receive emails or contacts from people that have tried to do something like this, or people that are interested in doing something like this. And so then we really can gauge then the volume of interest in our community, and also then, I guess, provide some follow-up to this, to our community, so that there's actionable steps, and through the newsletter too. So signing up for the newsletter and actually getting more insight about some of these referral sources.
Once you're signed up for the newsletter, to double plug that, of course, this could be the first time you're listening. We created a resources database that is a landing page with a database built into it. And it's only for subscribers of the newsletter. So it's what we're giving you in return for letting us communicate with you. After every episode, we are adding into that resources database, which you can just bookmark. And it includes whatever we spoke about in the episode. So some of the things like we know that the article we just spoke about will be in there, but the other topics that we brought up will add those resources so that you can refer back if you want to them. And we would love to bring guests on, where our goal is to have a live session where it's 3 of us and we can have a dialogue with additional experts.
Absolutely. I think it's just starting from a movement from the ground up and letting our listeners actually be the sources of future episodes and the sources of future continuum. So I think we're running up on time. Why don't we discuss the book? And I think the book fits into this entire discussion. The book that I would want to discuss is called Arriving Today, and it's from Christopher Mims. And the book came out in 2021 that looks into the supply chain of the author who ordered this nominal gadget from Amazon. And then he traces the entire complexity of the supply chain of this gadget being manufactured somewhere in Asia and then being shipped, like the shipment, the provision, the categorization, and then finally the delivery. So it's just a fascinating understanding and appreciation of this 99-cent Amazon phone cover that goes through so many steps, so many iterations. There's so much automation, but also so much efficiency built into the supply chain. And my parallel in a healthcare model is that we as healthcare providers can borrow from some of these efficiencies. We don't have to reinvent the wheel. All we have to do is we just look into the conversion industries and what they have done well. Like if we order something from Amazon, it's right there on your door, sometimes the same day. How do we borrow or how do we build a healthcare community that is also built on efficiency, where not necessarily speed, but quality? That I know that if I order an item A will arrive in a safe, effective manner at my door, and I'll be able to use it. If I need healthcare, how do I access a healthcare system? Through the supply chain, through the entire level of complexity of all the factors that are involved in the supply chain, right? There's the system factor, there is the provider factor, there is the social factor, there's the personal factor, and all of these factors build into the healthcare supply chain so that when I know I need to receive care, there's going to be care provided. But also when I need to provide care, I'm part of that supply chain. I am a physical therapy supply chain that goes for patients that are equipped for me. So I know that when they arrive through the referral, they will be an appropriate candidate to receive care through a structured method and then potentially move further along the supply chain. So it's definitely a worthwhile read, not a quick read, but a worthwhile read to understand this industrial supply chain. And then let's borrow some of that into our clinical supply chain.
You've probably heard this saying that there's no new ideas. We're just recycling them and saying them in different ways. And where we can borrow, not just new, think about ideas being represented in different ways, but I think my big takeaway from your explanation is why not just learn about what's worked in the past and tweak it and make it applicable for your own practice, your own career, whatever it is. I love that.
Absolutely. I think if you want a completely unrelated caveat of information, the ideas and knowledge, is it discovered or is it created, right? So do we create knowledge or do we just discover it along the way? And there's enough movement in determinism that there is no knowledge that is ever created. It is always discovered. It's out there.
Love that.
And all we have to do is just look for at the right spot, and now knowledge is going to be there. It's all there. Any point of knowledge, any point of information and data that has ever existed already exists, and we just have to find the right resource to bring it to us so that it's available.
That's, perfect. Before we end, I'm going to give one plug for something going on next week. It's completely free. It's called Healthcare Value Week. So for anyone who's actually made it all the way through this episode, Healthcare Value Week is once a year in the winter, and it's a week long. There's some in-person events, but what anybody here can do to participate and just to listen to the top thinkers in the value-based care space, just go online, Google Healthcare Value Week. I will put a link in our show notes. I have to get that out quickly because it's next week. And you can sign up for free to attend any of the virtual sessions, kind of like going to a big event where you pick where you want to listen. And then as long as you sign up, you can always listen to any of the other speakers. It's a lot of panels. And some of the great minds in value-based care are going to be speaking to big, broad audiences. So it's a great time for, true novices who just want to get their feet wet to listen, especially to some of the early keynotes. And if you happen to be in town, there's other things that potentially in DC, if you wanted to join, are available too. So Healthcare Value Week, it's a big thing in the value-based care world. And some of the people I look up to the very most in this industry will be presenting at this. And I hope even one PT listens.
Yeah, I know one PT that will listen. That's on the other side of your screen. But it sounds like an amazing opportunity. And the Healthcare Value Week, it's new to me. It's really interesting and definitely most likely going to be a time well spent because it will only add insightful information. So thank you for sharing that.
You're welcome. And thank you all for listening to us chat. And the brilliant Alex, I have so much fun talking to you. Could do this for 3 hours, but perfect time to end it and excited for our next episode.
Same, Dana. I appreciate it. Thank you for all your knowledge. I will be a sponge absorbing it. So thank you for
I am
this.
too. I'm learning from you. I love it. Okay. Have a good night, everybody, or whenever you're listening to this.